This conference will now be recorded.
Welcome to the ANCAN Advanced Prostate Cancer Group, and I'm Herb Geller, who's moderating tonight, and hopefully we can keep up with everybody as they show up and give everybody time. So I see we're getting to have a full house already. So I'll do the best I can. So while we're waiting, I've taken the role of certain people, and I will take the role for more, but why don't we have several new people tonight in advance, and so I think I'd like to just start off by talking to them initially, and then we can go back to our standard format with our members. So really, I'd like Stan Friedman.
Sure.
So the way we'd like to greet you is by asking a set of questions that really sort of helps get us together and get us all on the same page to go through, so where you are and where we are. So if you don't mind, I'm going to go through a series of questions to get some information from you.
Hold on one sec. Let me just shut off my phone.
Oh, okay.
Okay. Shoot.
Okay. Let me just do a couple. Let me do some housekeeping before that. Okay. Well, here we go. So tell us a little bit. How old are you?
75.
Well, I was there not long ago. And where do you live?
Stamford, Connecticut.
And tell us when you were first diagnosed with.
Well, diagnosed with prostate cancer this past December 9th when I had my biopsy. And then after that, went for a couple of scans, and they found out that, as someone said to me, the horse was out of the barn, and I had metastatic cancer invading a little bit of my pelvic area and some surrounding lymph nodes. Okay. And that was basically on New Year's Eve day.
Oh, well.
So what a way to start the new year.
Well, I had my diagnosis Erev Rosh Hashanah.
Oh, okay.
So did you know your Gleason score?
Yeah. In my biopsy, I had 10 out of my 12 samples were tested positive with Gleason scores of 8 and 9.
8s and 9s. And what was your PSA level at the time?
My PSA level was 5.7. So one of the reasons for the biopsy is that in the course of a year, my internist saw my PSA jump from 3.2 to 5.1, said I should probably, he was concerned about the jump of over a point, and then said you should go see a urologist, and etc.
So which urologist did you see, and where are you now?
Well, right now I'm being treated at Sloan Kettering. Okay. After interviewing, I think that's the best word, 3 medical oncologists at Weill Cornell, Yale, and Sloan Kettering, and I chose the doctor at Sloan Kettering, who is also the head of prostate cancer there.
And who is that?
Dr. Morris.
Okay. So what about scans? You said that they found Metz in your liver.
No. In my pelvic area.
In your pelvic area and lymph
nodes. A little bit around the lymph nodes.
So that was through what? Did you take any other kinds of scans?
Well, other than the bone scan and CT scan, I've had since then a bone density scan, just to create a baseline for my bones, and I've had a CT scan of my upper chest to see whether the cancer had in any way invaded that area, but both those turned out to be good.
Okay. So given that you were diagnosed in December, what kind of treatment did they decide for you?
Well, kind of the standard treatment. I'm on a shot of leuprolide every every 3 months. I'm taking abiraterone and a small amount of prednisone to counteract some of the abiraterone of impact. I've also are having my biopsy samples go through genomic profiling.
So what about did they do genetic profiling on you? Did they do any germline profiling on your for you?
No, I don't think so.
Okay, because it would, I mean, some mutations that are particularly troublesome are considered, like, for example, BRCA1 and 2 are germline mutations.
Yeah, no, the genomic profiling also includes some genetic profiling as well, where they're looking for BRCA1, BRCA2 genes, mutations.
Okay.
So they'll be able to determine that in the if they need to administer immunotherapy, and I'm a possible candidate for what they have on the shelf.
Okay.
Herb, can I just say, I just want to bring out a distinction here, that yes, it does include BRCA, but you're not likely to know if those mutations are germline or somatic. And the reason I mention it is because Foundation Medicine, I know that Memorial Sloan Kettering doesn't use Foundation Medicine, but Foundation Medicine has just created a new partnership so that if one of these mutations comes up, which can be either or, they can then go back to Foundation and order a second test to determine if it's germline or not. So I just wanted to mention that to everybody. This is really new. This is within the last 2 weeks.
Great. So then the questions, I think we see where you are. So two things. How did you hear about us?
Okay.
How did you hear about ANCAN?
Well, I am currently participating in 100 Miles in March challenge that's being sponsored by the Prostate Cancer Foundation out in California. And part of it is also a fundraising, and one of my fraternity brothers donated, and he knew another fraternity brother whom I really didn't know, who came in after I had left college, by the name of Paul Frieda. And Paul contacted me and recommended that I look you guys up.
Well, Paul is with us tonight.
Oh, I didn't see him, so.
So great. And then finally, what questions do you have for us, and how do you think we can help?
Not sure. I mean, I guess my biggest desire is to keep up on what's going on in the field, assuming that changes have to be made for my treatment, and I have to take part in the decision-making process of where to go if my current treatment kind of bails, or my cancer becomes prostate resistant. Prostate resistant. So I thought participating tonight and seeing how the group operates and the exchange of information would be helpful. I'm just looking for whatever I can do to become more informed.
Great. So one other quick question. So since you've been on ADT and abiraterone, have you had a PSA measurement?
Yes. Oh, I'm sorry. Yes. My last PSA measurement, which was taken a week and a half ago, was 0.89.
Okay, so you're certainly responding to treatment.
Yeah.
But and have they asked you about, has anybody thought about radiation for the lymph
Oh,
nodes?
yes. So radiation is, I'm glad you're prompting me with all of this. Radiation is on the horizon in about 3 to 6 months. I've already met with the radiation oncologist at MSK, and depending upon how I'm responding to the medication, the rate at which I'm responding, and also my prostate shrinking, they will schedule radiation within that time frame. And I'm also scheduled to take another set of scans in late April.
Great. So I think that really gives us a background where you are, and I think I'll throw it open to members of the group to ask any questions that I think I might have forgotten.
Who's the radiation oncologist that you've seen, Stan? This is Rick.
Well, Sloan has a satellite operation in West Harrison, New York, which is about a half an hour away. My doctor's in Manhattan. The radiation oncologist. The name escapes me, but I'll look it up. It's somewhere on my computer.
Is it Boris Muller?
Yes, no, it's Boris Mishoshek. And he is the chief radiation oncologist for that satellite operation, and also in someplace in New Jersey.
But does he do mostly prostate is the question. We know Boris Muller.
Yes.
He does. Len, isn't that where you went to begin with? And isn't that where you saw Boris at the that Westchester facility?
Yes, I did, Rick. And Boris Muller had since moved to an MSK facility in New Jersey. But I do remember there being another Boris radiologist at the Westchester facility, and that's the one Stan is seeing.
Okay.
I have a question, Stan. You mentioned something about lesions in the pelvic area. Was that bone or lymph?
Bone.
Okay.
Bone. Identified 4 small areas.
Right. Okay.
So a couple of things I just like to throw out, and then we'll get some maybe feedback from some other guys. First of all, the treatment is, very much the sort of standard of care treatment that you're getting. You don't have that many spots. Maybe you didn't tell us how many pelvic spots, but pelvic spots.
About 4.
4, including the lymph nodes or excluding the lymph nodes?
Excluding the lymph nodes.
And how many lymph nodes?
Unsure about that.
Okay. I mean, it's sort of right on the margin of whether you have high volume or low volume disease. So
they're considering it low volume.
Okay. So the one thing that you don't want to lose track of, and this may be the radiation therapy that is on the horizon for you, because we didn't say if that was spot radiation or if that was going to be to the gland and to the pelvic girdle, is that nowadays it seems like the standard of care is growing more and more towards treating the primary, which was never done in the past if you were diagnosed de novo metastatic. So do you know if the radiation they're talking about is just to the spots, or if they're thinking about treating your gland and the pelvic girdle?
No, at the moment it's just the gland, from what I gather.
Okay.
Yeah,
The gland
I think that's why they're doing the set of scans in April.
Yeah.
To understand what they might do.
So, you know, one thing I think that's worth digging into a little bit, because we've seen too many guys where they came in and radiated the gland, but they didn't radiate the pelvic girdle, and then there were issues with the pelvic girdle, is definitely to raise the possibility or to have the discussion about radiating the pelvic girdle as well as the gland.
Yep. It's good advice.
But from I guess from the perspective of where I am, I think you're sort of on the right track, right? I mean, things are going in the right direction, and they seem to have their appropriate therapy planned for you. We always recommend that you be treated at a major medical center. Certainly, you can't do better than Memorial, or you can, but it's in your area. That's
it.
I mean, frankly, between Memorial and Cornell and Mount Sinai, you've got it covered in Columbia too, in the city. I mean, there's no question that there's incredible expertise in the city. So I guess, does anybody have any other questions for Stan?
This is Al Latimer. Yes, has your doctors discussed the PSMA-PET scan as to further determine where your cancer is?
Yes, I raised that issue at my last visit with the doctor, and he felt at the moment it was inappropriate. Or inappropriate is probably not the right word, but that he didn't think it was necessary at the time. But I did bring that up after listening to a participating in a 3-day virtual conference that the major centers of which you just referenced basically came together, and there were a whole score of doctors that focused on prostate cancer and gave seminars on each of the and many of the advances that were happening in the area at the time. One of them was specifically on PSMA-PET imaging.
Which conference was that? The 01 or the PCF one?
It was the 01.
Yeah, the 01 was a little lacking in my judgment, but we can talk about that later for a whole bunch of reasons. Anybody in the group who's been through this have any words of wisdom for Stan? Not necessarily about his treatment, but anything they want to say to him other than keep coming back.
Yeah,
This is John in Connecticut.
I mean, there are several of us on Abby and prednisone here, so you certainly have a peer group within this very screen, and so we're all kind of, we're all thinking that this is what seems to be working for now.
Right.
Stan,
So I think
this is Peter. I welcome to the group, but I must say I'm very impressed. For someone who was diagnosed only a couple of months ago, you seem to have grasped the situation very well. You've educated yourself. You've got a handle on it. You know exactly where you are. Made some very correct and studious choices. I'm impressed. Not everybody comes that prepared, that recently diagnosed. My question is, do you have family that had prostate cancer, or father, brother, or anything like that?
No, I did not. But when I went through the family tree, when they were looking for history, it was amazing how many of my family had some form of cancer or another, and died as a result. And with regard, just as a follow-up to your knowledge, I mean, I believe that knowledge is power, and if I'm not involved in these decisions that potentially may happen along the line, I'm just stupid. And the other thing is that someone recommended to me, which I'm sure you guys are well aware of, a book by Patrick Walsh on living with, I think it was how to live with, survive with prostate cancer, etc., which I read like 3 times to absorb all the information in there, and I just been keeping on doing my homework.
Very good. Well, welcome. I mean,
Great.
that's our
Yeah.
motto, is how to be your own best advocate here, how to educate
Right.
and speak up for yourself. You're doing an excellent job. And as more of these tests unfold, I'm sure different things will come up. I mean, I myself did genetic testing, and that has guided some of my therapy over the last several years.
I have a comment. Stan, is the oncologist at MSK genitourinary?
Yes, he
Yes.
is. Yes,
What?
he is.
Yes, he's chief.
Want to double check on that? Okay.
Yeah, I think it would be unusual at MSK for them not to get you to the right specialist.
Yeah.
Right. I mean,
Boris is one of the best. I'm surprised you got an appointment with him. It's not easy to get an appointment with him.
Well, I had, to be perfectly frank, I had a son-in-law who knew someone at MSK, and I got an appointment.
all right. Well, whatever works.
I mean,
for sure.
unfortunately, sometimes that's the way things happen.
Yes.
Hey, Stan, I
Right.
have a question. I have a question for you regarding your history pre-diagnosis. Like, were you getting annual PSA tests? Did you have any symptoms before you were diagnosed?
None whatsoever. None whatsoever. As a
No,
matter of
and-
fact, the only thing I knew about my prostate was that it was getting bigger, which is, you know, kind of typical of men who are getting older. The tests didn't indicate, or at least no one felt any tumor on the prostate. And it wasn't until it jumped a little bit over a point that my internist said, I think it's time to investigate.
Mhm. So I do have one other question, Sam. Do you have kids?
I have 2 kids, but they are both adopted. So I have
Okay.
no right in if I get a BRCA1, BRCA2, you know,
It
diagnosis.
won't be passed on. It
It
wasn't
won't be passed
on.
on. Correct.
This is
Okay.
John, and I wanted to welcome you to the group too. I'm in Connecticut as well. And, you know, your stories, like practically everyone here, that for me, as you told your narrative, the critical moment was when you said the horse had gone out of the barn on New Year's Eve. And there's 36 guys here have had that exact experience and know what it's like. I was also wanted to put in a note of thanks for your internist and urologist who were able to take the initiative to get that biopsy while your PSA was still in the normal range. Because having had the opposite, you know, where I went from, you know, doubled and doubled again, but I was still in the normal range, and they didn't think it was necessary to do a biopsy. You know, I might have got caught before I was metastatic, who knows? But I really appreciate when I hear a story about somebody getting taken seriously when their
Yes.
PSA is still in the 3s because it came from the 1s, or still in the
Right.
4s because it came from the
Yep.
2s.
Right.
So anyway, welcome to the group.
Yes. Well.
Thank you very much.
Great.
I have a question for the group. Hi, Stan. It's David Muslin out of Chicago in Florida. I'm surprised, and the question is really for the group, and maybe Stan, you can answer this question too. I'm surprised they haven't done a PSMA test on him yet to find out where the lesions are and to identify them. And I know you talked about radiation 6 months from now, but I'm surprised they're not a little more aggressive about that. Any comments, thoughts?
Not that I have. All I can tell you is that, you know, he and I, my doctor and I discussed the PSMA and didn't feel it was necessary at this time.
Great. So look, we do have some more new people, and we want to welcome you and hope that you learn from. We can, you know, join our brotherhood and contribute and learn. But I do want to move on because we have several new people in addition tonight. So thanks very much, Stan, and we'll certainly
Thank you, Herb.
hope to see you in the future. So, but what I do before I want to move on to the new people, I'm going to call a roll for the people who I missed and ask if you need some time. So for example, David Muslin, do you need some time tonight?
I'm good, Herb. Thank you.
Okay. Gary Peters, would you like some time tonight?
A little bit.
Okay. James Barnes, would you like some time tonight?
I'm good, Herb. Thank you.
Okay. Jerry Deans, would you like some time tonight?
No, I think I'm good, Herb. Thank you.
Okay. Jim Jeffries, would you?
I'm good tonight. Thanks, Herb.
Okay. John A., would you like some time tonight?
No, thank you, Herb.
Okay. And what about John I.? Would you like some time tonight?
No, thank you, Herb.
Okay. Now we go on. I'm just looking. Ken Anderson, would you like some time tonight? Ken, you're muted.
You know, at the end, I do have lab reports. So if you have time at the end, I'll give you an update.
Well, we do want to make, I think we'll be good. The next, Peter Monaco, would you like some time tonight?
No, Herb, thanks very much. I'm fine.
And I guess that really, I think, is there anybody I missed? Because I think I covered everybody, but please, Jim Schrade, would you like some time tonight?
No, I don't need any time tonight.
Jim, are you okay?
Yeah, I'm fine. Thank you. I don't need any time.
Okay. And Joe Murgia, would you like some time tonight?
No, thank you.
And
Okay.
Dennis Correa,
Dennis Correa.
don't forget Dennis.
Yep.
That's okay. I don't need any time. Thank you, guys.
Dennis
I was late
McGuire.
anyway, so I don't deserve it.
Dennis McGuire, would you like some time tonight? I thought I saw Dennis McGuire.
No, I don't think so.
Maybe, all right, that was my mistake. I highlighted the wrong name. Great. Okay, so our next person I guess I'd like to talk to is Bruce Bosian. And evidently Bruce is known to some of you, but I think he's new to this group. So Bruce, I'm going to kind of go through some of the same things that I went through just now with Stan, with you, okay?
Sure.
And I'm going to ask, if you're not speaking, could we mute? I think I hear some background. Okay, so
That's
Bruce,
coming,
welcome
Bruce.
to our.
That background is coming from Bruce. He may have his volume up too high.
Oh, okay. Bruce.
Does that help?
Turn down your volume. It does.
Does that help?
Okay, yes. Okay, so hi, Herb Geller and the group. And so tell us a little about you. So for example, how old are you now?
I'm 64 years old.
And where do you live?
I live in Valparaiso, Indiana now. Just been here about 3 years. Most of my life in the Chicago area.
And when were you first diagnosed?
In the fall of 2013.
Okay. And at that time, do you remember your Gleason score? Did you have one?
I should have looked at stuff before I got on this. It's been so long. I want to say it was in the 8 to 9 area.
Okay, so it was already considered advanced at that time, right? High risk.
Yeah, I guess.
And what was your PSA at diagnosis?
I want to say 5.
Okay. And then how was that picked up? Was that picked up just again, like we just heard, through a routine physical, or were you having symptoms?
I had no issues at all. And matter of fact, I had a physical, and the doctor told me If you keep it up, I won't need to see you for a while. You're in the best shape you've been in ages. And 2 weeks later, he called me up and he says, your PSA went up and we need to take a look at that. So he recommended a urologist, and he immediately suggested a biopsy. And I had that, and I guess I had in my prostate, I guess about 75% is what he told me.
So what treatment did they start you out on?
A radical prostatectomy. Okay.
And then what after your RP, your PSA went down?
Yeah, it was undetectable. It was about 0.01 or 0.01, depending on whether it was a regular PSA or an ultrasensitive PSA.
Okay, so tell us about what's happened lately.
Okay, so it's been good all this time. And just recently, it went up to 0.18. And I'm sorry, 0.20. And that was a regular PSA. So the doctor says, well, let's wait 2 months and check it again. And so in 2 months, we did an ultrasensitive, and it was 0.18. He says, well, that's good. So let's check it again in 2 more months. So that went by, and just recently I had it, and it's 0.24. So he says that, that's the threshold of chemical recurrence, as he called it. All right.
So where are you being treated now?
Right now, I'm not being treated anywhere. I'm with Dr. Coyer he's out of Advocate Good Shepherd in Barrington, Illinois. And so my last visits with him have been on Zoom due to the fact that I'm now about an hour and a half away. So if I were to go for any treatment or things like that, I'm just out, a little over an hour outside of Chicago. But anyway, he recommended an Oxman PET scan. And to get that scheduled. So I got that scheduled at UIC, and no, I'm sorry, at Northwestern Memorial. And I reached out to my old friend Rick, who back in the old days, when I first started with this group, I was in John Teesberg group, and I met Rick, and I traveled quite a bit in my profession. And I was going out to San Francisco one week, and I said to Rick, I said, hey, can we meet for dinner? And he says, absolutely. So I flew out to San Francisco and drove over to Sausalito, and Rick and I had dinner. So where I was at, just to kind of wrap this up, I had one positive margin. And my doctor said, here's where you stand. We can do radiation now and knock this out, or we can do surveillance. So Rick recommended Dr. Moran, who is like the guy in radiology, especially in my area. And I went and met with him, and he said, look, it's 50-50. He said, that's all I can tell you. I said, you can't give me anything more than that. And he said, no. He said, either way you go, I'm supporting you. Well, at the time, I was not in the mood for 6 to 8 weeks of radiation. So I said, I'm going to hold off and let's do the surveillance, in which I get my PSA checked regularly. In the beginning, it was every 3 months, and then every 4 months, and 6. And I'm at where we do it every 6 now. And so so now he's saying, do this Oxman PET scan. So I went, wait a minute, I need to reach out to Rick. So sure enough, Rick remembered me. He actually remembered me telling me to go to Dr. Moran. And again, this is back in 2014, 2015. And he remembered me and remembered all about me. And he asked me what my PSA was. I said 0.24. And he said, wisdom is that an Oxyman scan will not detect, probably will not detect anything with the PSA that low. And he says, in reality, a PSMA probably will not either. One being the Oxyman at probably at about 0.8 PSA, and the other one at 0.64. So I reached out to my doctor today because I already got this damn thing scheduled.
So
And
is your doctor a urologist or a
yes,
medical oncologist?
he's a
So your doctor's
urologist.
a urologist. And
Right.
does he specialize in, I mean, do you have a potential connection with a medical oncologist?
No, I don't. But he specializes he specializes in prostate cancer.
Okay.
I mean, that's his thing.
You had your biopsy years ago. Did anybody ever mention genetic testing for you?
No.
Okay, because it's still possible to do genetic testing either on the samples that you had from before or from liquid biopsies of what's going on in your body now. And did you ever do what about germline testing? Was that ever done?
What testing?
Germline genetic testing. So there are two types of genetic testing. One is to test if you carry any mutations within you, and the second is if the tumor has mutated, has mutations in it.
No, neither.
Well, it might be advisable even at this point, I would say, to think about just getting germline testing.
Okay.
Because that will tell. Yes.
Can we go back? Can we just go back to what the Euro said when Bruce discussed being a little low for an Axumin? What did Koya say to you, Bruce?
Okay, I first of all, I did my research on it, and and everything you told me was accurate, and I looked at a lot of stuff, and sure enough, that seems to be in that direction. So the next thing was to see where I can get a PSMA done in this area, which actually Northwestern does not, which surprised the hell out of me because they're usually cutting edge, and they do not. Now, the only other place I found around here was Indiana University, which is doing they're doing pre-trial testing of it. So I'm trying to nail down a place. So anyway, I reached out to my doctor today, and I sent him an email through my portal, and I told him my concerns. The office called me back, and they obviously want to set up a call to go over this, another Zoom call, or to come in. But the problem with that is the Zoom call would be after the Oxyman scan, and the face-to-face would be right before it. And if you know anything about these, you've got to order them well in advance so they can get the dose for the PET scan.
Right.
And so I had to do that already for Northwestern. So that was Friday. And so they've probably already ordered that. So they're supposed to call me back tomorrow to see where we're at.
Okay. Well, a couple of quick things I just want to say, which is it's not your problem if you don't show up for the dose. That's the hospital's risk, and that's Axumin's risk. Secondly, and what I really would like to ask the group, because I think this is what you need to figure out, is who else has been in a situation where your PSA came back, you're not on any treatment at all, you're tempted to get the Axumin or a PSMA, but your numbers aren't there, and so you're faced with this debate whether you wait and let it get high enough so maybe we can see something, or you dive into treatment right now. And the problem with diving into treatment, of course, is that then it pushes your PSA down and you're not going to see anything on the Axumin scan until your PSA goes up again. So who's had some experience with that? Anybody? Is that Ted Healy?
Hi, yeah, Ted Healy. Hi. I do. I think I do. I was faced after my prostatectomy with persistent cancer. The PSA's range were in the 2 range. So I did have an oxygen scan done. It did show activity in my bladder neck. I went forward with 36 IMRT radiation and 2 3-month shots of Lupron. It's currently undetectable. I'm due to have another PSA next week, actually. And thanks to this group, I've set up an appointment with Dr. Grass in OHSU. So I did go forward with it for me.
Oh, okay, you said it was 2. Was it 2 or 0.2?
I'm sorry, I keep doing that. 0.2. One was a point. One was 0.1 something, and then the next one they averaged out to be above a 0.2.
Gotcha. Thank you.
So Bruce, this is
you decided not to wait, but to go forward with the radiation. How much after your radical prostatectomy did you do your radiation?
Was that for Ted?
Yes, that was for Ted.
That was, very, very shortly afterwards. My prostatectomy was May. My radiation started roughly around, I'm guessing, September.
Yeah, so, Bruce is a really different situation because we're already 6 or 7 years out. Now it's starting to climb. So anyone else had this issue with scan versus wait versus scan?
Yeah, Bruce, Peter, and the way you described it, it doesn't sound like your PSA is jumping that fast. It's not. It's not. So it's not doubling. I mean, the red flag for doubling time is usually 3 months, and it's going up like 0.04 in 2 months or something like that. It's not doubling yet. I know it's dicey to think, oh God, it's going up. But if it was me and it's been me, I would wait and see how, because this is slow moving disease and it's not going to get out of control. And if you can live with that, because I agree, you want to be able to scan it and see where you're shooting and not just shoot arrows all over the body at it.
Right. And that's just it. I mean, just up until recent, it's been 0.01 for the longest time, and then, like you said, it just within the last year just did this slow creep, and then, like I said, I had 0.2, then it went back to 0.18, and now 0.24. So, I don't want to go have this scan if it's going to tell me nothing because of the fact that my PSA is too low for it to detect anything. Because to me, that's just a waste of time and money. I want to go get a test where they say, hey, you're gonna know something at least. This is a shot in the dark.
Okay, so let me make a comment. This is Alan. I had some of that situation. I had a rising PSA after prostatectomy and radiation, and eventually it got up to roughly 0.2 or thereabouts. And I opted, Sloan Kettering told me you ought to do an MRI just to see if there's anything there. And I said, well, why bother? It's such a low PSA. And they said, sometimes you have a critical mass and, it's just one area and it will pick it up on an MRI. Okay, so I did that. It showed nothing. But then I did one of the PSMA scans. Now, I did it when the PSA was about 0.2, and I knew it was unlikely to find anything, which is what happened. It didn't find anything. But my thinking, and this is the point I want to make, is I didn't want to have any regrets down the road that I could have found something, and maybe I could have radiated that one spot and held off future treatment for that much longer. And so that was the reason I did it. And it's the same reason I did it when my PSA went to 0.5 and had another I had a PSMA scan. I also had an Axelman scan along the way because I didn't want to have regrets. So it's just something to consider.
Oh, no, I agree with you, and I feel the same way. The problem is with the Oxyman, the chances of finding it at this point are so low. So that's why I said to my doctor, I want to opt for the PSMA.
Yeah.
And the reason I'm thinking that, and I may be totally off base here, that he didn't recommend that, maybe there's nobody in my area that's doing that yet. I don't know. Could I be
So,
wrong there? I mean, all you guys are mentioning
Yeah, no,
PSMA like it's, you know,
it's probably
common.
true. John Ivory, do you know if there's Bruce says there's nothing going on at Northwestern. John or David, do you know if there's any PSMA scanning going on at all? Because you guys are pretty close to Northwestern.
you can run a quick.
I have not been able to get a PSMA scan at Northwestern. I was always sent to University of Michigan both times.
Okay.
And who pays for it?
There are more and more trials coming up, because of the latest technology. It's worth a little research on the clinical trials site for the government and take a look.
Right, and that's why I've got 2 calls in today to the Indiana University because they are doing trials.
Perfect.
And I am trying to do that. Now, as far as the Oxman PET scan at Northwestern, my insurance will pay 100% of that. So it's not like I'm paying anything out of my pocket to do it. But again, I don't want to go and do a test just to go do it.
Okay, guys, for those of you who are new, please monitor the chat window.
The chat box.
It's the little white bubble in the top right-hand corner, and Joel Blanchette, God bless him, has just put in about 10 trials there or something like. I don't know how many, but there's a whole bunch of trials in the chat box, and of course we'll copy them and put them in the recording afterwards.
Okay, yeah. Okay, so I'll be able to get to those afterwards, right?
You will.
Just another word for everybody. If you're on a PC, the chat is automatically saved in your documents under chat log, and then it'll say Baniska, so you'll find it. You don't have to do anything. It's also automatically saved on a Mac, but I can't tell you where, but it is there. Don't worry.
I'll have to look for it later because I'm on a Mac.
Okay.
So,
and then it's also, and for those of you who don't know, we copy the chat and we put it, when we post the recording, we put it in the recording, and sign up for the blog, it's on the blog post.
Well, I just copied it all. You can highlight it, and I copied it all, and I'm just going to paste it, and I'll have it.
Okay. That works.
Are there other questions for Bruce? Any other comments from people? I mean, I think it's, the question is, what do you do? I mean, either you wait and see if it gets any bigger, or, I mean, we heard from Alan about the possibility of just, kind of trying to cover your bases in case it's sort of localized in one spot, you might find it. I don't have any, Peter, you would probably say, wait. Huh? Yep, he's shaking his head.
Well, I have one thing to say, Bruce. For goodness sake, don't wait another 7 years to come back and say hello to us.
No, right, don't wait. Right. 7 years is too much. We want to see you sooner.
I promise. And I just want to say one more thing, because you asked a question about how did I find out about the group? Well, when I got Peter Walsh's book back in 2013, the first line in the book says, if you're reading this book, you must have become a member of the Reluctant Brotherhood. And I went, Reluctant Brotherhood, what a cool name. So I Googled it. And sure enough, I came across it. And that's how I found it.
There you go.
Okay.
The only person I think who was, there are 2 people who might have been on the group when you were originally on it. One is Jake and the other is Len. Other than that, I don't think anybody.
Well, hopefully that's not because of bad news.
No, unfortunately, sometimes it is, yeah.
So
okay, well, thank you for inviting me back, and I look forward to joining more often.
Right. we'll see if we hope we can be helpful. So I noticed Rich Jackson just joined us.
Yeah.
So Rich, is it because you didn't set your clock ahead?
No, the clock knows exactly what time it is. Just got tied up elsewhere.
Would you like some time tonight?
No, it's still quiet on the Eastern Front. Thank you.
Okay, great. So we have a couple more new people, and I'm afraid we may not. Dave, we've tried to, because of so many other people, we're trying to keep to 3 new people a night, and so Dave, would you mind if we discussed your situation next week? Or do you have something urgent that you'd like to discuss with us?
Nope.
So
I'm not sure which Dave you're talking about. Is there more than one Dave?
We got you. You're the right Dave.
You're the right
No, I
Dave.
don't mind.
Okay. So please, we'll be meeting next week, Tuesday at 8 o'clock. And I think, Rick, you'll be in the, who's going to be in the chair? You will be, Rick, or I think.
That's Tuesday, 6 o'clock Eastern.
Tuesday, 6 o'clock Eastern, right.
Len.
So in the meantime.
Len's in the chair.
Oh, Len's in the chair, right. So Len, you'll be taking care of Dave next week.
Yeah.
So our
All right,
third new
Dave, we'll
person.
see you next week.
So our third new person is Chris.
And
So
now we
Chris,
got Mike Hanley as well.
Right. I thought Mike had been with us in the past, but maybe not. I think, well, Mike, I'm going to ask you the same question that I asked Dave. Do you have something you really would like us to help you with this week, or?
So,
I'm sorry, Mike?
All right, we can't hear you, Mike.
I really do, and I think I'm in a fairly serious situation, and I do have some questions.
Okay, so let me then ask Chris, is there something that you feel like you need to do?
Herb?
Yes?
Are you sure you're unmuted?
I'm open. Turn my volume.
Mike, we did have trouble hearing you.
You're muted.
I am not.
Okay.
Mike, we'll come back to you in one
Herb,
second.
can you hear me? This is Mike again.
Yeah.
Yes, we can hear you.
Just hold tight,
Okay, can you hear me now?
Hold tight for a sec. So Chris,
okay,
we welcome you. And is there something that you feel that you would like to discuss tonight, or is it something that you think we could wait till next week?
Okay, this is Chris. Are you speaking
Right,
to me?
yes, indeed.
Okay,
to
just
you.
With all the faces and all the initials, I'm kind of scanning all over the place. Actually, I'm very new to this, and I'm not acute, as all of you are. I'm probably low to medium. I joined this crowd about July of last year, and in October, after having verbally cudgeled my doctor.
Chris, can we interrupt you? Here's the question. First of all, just tell us, do you have advanced or recurrent disease?
No, not yet. That's why I'm just here observing. That's why I didn't jump in.
Right. So we need to move you to a different group. This is
right.
The group you should be attending is the low and intermediate group, and that meets next Monday night at 8 o'clock Eastern, and it'll be moderated by Peter. Peter, do you want to welcome Chris to your? Do you just want to give Chris a quick welcome to your group and tell him how to get onto it?
Sure, Chris. If you can,
Jim Marshall has sent me the links, to this because he wanted me to at least listen and observe. And that's why I didn't jump up and say I wanted time until you came back to me, Herb.
Okay.
Great. Well, listen in, and if you could put your email in the chat window, we'll make sure that you get my notice for next Monday's meeting.
Okay. This is a fairly vertical learning curve, so I'll have to figure out how to get to your chat mail.
A little bubble that's
right
next to the people and between the people and the wheel.
Okay. I think I'm in it now. So yeah, I will do that while you guys continue, and I'm going to mute myself so I don't interrupt.
We'll speak. We'll make sure you have time on Monday.
Okay. Well, thanks, Chris. So, Mike, we'd like to talk to you and learn about your situation, and welcome to the group. So I'm going to ask you these same questions. So tell us, how old are you? Okay, we can't hear you.
I just want to thank you for letting me come on.
Well, you're very welcome.
I want to thank. Can you hear me now?
Yeah,
yes,
Mike,
but
can we suggest that you turn your camera off because it sounds like you don't have good bandwidth there, and we're not hearing the volume as much as we'd like to look at you. It might be better to turn your camera off, and then we would hear you better. There you go.
Okay, so Mike, how old are you?
Okay. All right, how's that? Oh, I'm 70.
So I
Still can't hear me?
about you guys, not well.
Mike, you might want to try logging off and logging back on again. Sometimes that helps. And meanwhile, we'll go on to somebody else.
Right. I think that's probably the thing to do. So, Mike, we'll come back to you once you log on again.
And if the other thing, Mike, is just consider calling in. If you've got, I sent you the reminder and the call-in instructions are there, and it might just be easier tonight for you to call in on the telephone. The number and the code are all on the bottom of the email I sent you.
Okay, well, Mike, we'll be back to you in a few minutes once you call in. So I think given that we're back to our regular group, we can start. And Jimmy, why don't you tell us how things are?
Hello, hello.
Hello, hello.
Hello,
hello. You know, my experience at the hospital, I'm getting better. I'm healing. I got the artificial sphincter installed 2 weeks ago today. And it has been harder recovering from this than I thought it would be, although I don't know why I thought it would be easier than it is. There's a lot of tightness in my abdomen. There's a lot of soreness in the scrotum. It's not easy, but I can do all the things I couldn't do 2 weeks ago, like tie my own shoes and turn in bed. That's the way it started out. The thing that, you know, I assume that as I go on in 6 weeks, and the PA, the physician's assistant that saw me and recatheterized, or I should say, she decatheterized me 2 days after I left the hospital, has been really, really great. But my issue, you know, is really revolves around things that started at the very beginning. The surgeon at Johns Hopkins told me in my hospital bed he was going to call me the next day to discuss the pathology report. He didn't call. 2 days, 3 days, 4 days later, I called, kept calling, kept trying to get a hold of him. A week and a half later, he called, and he was apologetic and he was nice and all this. And he said that he thought that he's going to refer me to a clinical trial, and he thought that I had, you know, a somewhat favorable situation based on that I had a 4+3, even though the other aspects of my pathology were not good. I said, okay. So I went and get the clinical trial, and then the radiation oncologist in his follow-up, this is fast forward through the abiraterone, through the Lupron, towards the end of the Lupron. The radiation oncologist, he followed up And I said, well, how's it looking? And he said, everything looks pretty good. And I mentioned to him what the surgeon had said in his call that was 2 weeks late about the 4+3 being, one of the few bright spots in my pathology. And he said, well, you do have tertiary 5. Now, I wasn't upset because I had tertiary 5. I was upset because it was 18 months later and no one had told me that. And his response to that was, do you have someone to talk to? And so I lost my membership in his fan club kind of at that point. I just thought that was an odd thing to say. And I wanted to say, well, I thought I was talking to you, but he was making it clear that wasn't his department. His department was to tell me about the tertiary 5 and so forth. So anyway, that all being as it may, I sail on, I go ahead. Then I realize my incontinence is relentless after 18 months. I just give up to get the urinary sphincter scheduled. Hard to schedule because of COVID. It's an elective surgery, but I got it and I got in there and I had it done. But the problem wasn't that I didn't get any sleep the whole night after the surgery because of a very loud roommate and the drugs don't work. They work, but they worked me over at the same time. So I had no sleep. And then the next day I'm supposed to just pee and go home. When they remove the catheter, you pee and you go home. Except I had so much swelling down there that I couldn't urinate, and I just kept drinking more and more and more water, trying to overhydrate myself. No one stopped me from doing that. And then when it got to be really uncomfortably full, and I realized I had made a mistake by trying to force it out by drinking so much, they said, well, we'll just get somebody from the surgical team to come up and recatheterize you, except they were in surgery. And evidently there was no other doctor in that entire wing of that hospital who was able to come and recatheterize me because of the placement of the urinary sphincter was very particular, and they had to have that particular expertise in that to be able to do it, and they didn't have anybody available. So I got an ultrasound that showed that I had about 750 milliliters and growing of urine in my bladder, which was really, really, really uncomfortable. I'm not a tough guy, but I'll just tell you, it was not good. And from that point, it was 90 minutes before they finally freed up a surgeon to come and recatheterize me. And it was traumatic, I have not had anything like that happen to me in this course of this treatment, but it seemed to be another, like the third chapter. And so it kind of felt like, things, the surgeons are good at what they do, and the nurses are sometimes good at what they do, and the schedulers are sometimes good at what they do, but nobody's good all the time. And sometimes the price that you pay is to have a traumatic experience, and I understand that. But I kind of felt, and I'm not going to go back and say anything to them, but certainly they should have a contingency where if a guy has got to be recatheterized and there's only 5 people in the whole hospital that can do it, and they might be unavailable because they're in surgery, it was hard for me not to get an attitude about that. But anyway, it's all over now, and I'm recovering, and it's slow, but it's good. Hopefully the urinary sphincter works. I have to go and see this radiation oncologist again for a follow-up. I don't really want to talk to him, but he wants a PSA and testosterone that I'm going to get on Wednesday instead of the one I was scheduled to get in May. So he's going to talk to me about that, and I'll just have a nice visit with him. I don't want to throw him under the bus, or I would fire him or whatever, because he's not involved really in my care anymore except to follow up, and he's not even my main oncologist. So that's where I'm at.
But Jimmy, how is the machinery working?
Well, it doesn't work. For 6 weeks, you just let it heal, and then they activate it after 6 weeks.
I see. Okay.
So right now I'm as ever, but it doesn't bother me as much because it looks like the finish line could be coming. So I don't want to sound negative. I just kind of like that hospital visit was, it could have been avoided what they did to me. That's all.
Okay. Well, hopefully you're on the mend.
I am. Move on. I got no complaints. Now that I'm complaining to you guys who pretend to care, I'm good.
Pretend?
I'm just kidding. It's very good for me to check in with you guys. And
well, we're all good actors.
Yeah, all's well that ends well, even if it doesn't go perfect. And all of us have had problems with surgeons.
Nobody, I don't think I can't imagine any one of us where things went perfectly.
Exactly.
Jimmy, I have a question. Do you have to catheterize until you can start using the artificial sphincter? I mean,
no,
how do you avoid?
No, It's a weak stream, and it's kind of I have to mind it carefully because it has a, you know, as sometimes when you have a weak stream, it goes in different directions and it dribbles and stuff. But I'm able to go. I don't have to be catheterized. They cannot catheterize you for the time that they would for a prostatectomy, you know, 8-10 days or whatever, because they don't want a catheter to be near that apparatus.
Okay.
So that makes it different.
Got it. Right. Well, I'm glad to hear that things are on the mend. So,
great. Get me out of here.
We'll get you. Well,
Jimmy, I've got a
Peter?
quick question for you because I was on a catheter for 8 months before my initial diagnosis. If you ever had a problem with urinary retention, this means you couldn't just go to an emergency room and get a catheter. You'd have to somehow schedule with an expert surgeon, right?
That is something I had not even thought of. Thanks for nothing, Peter.
Well, just ask that question if it ever comes up. You know,
good question.
What's the procedure?
I have not even given it a thought, and that's a really, really good point. Now I'll have to consider that because I can't just waltz into a hospital and say I need to be catheterized. They're, you know, knowing, see, again, they may not ask me the question, you know, do you have anything in you? Although they usually do, and I say, got a hip replacement, and now I'll be saying I have a hip replacement and an artificial catheter. You know, my goal is to have, I'm going to leave a really expensive corpse when I go. So I'm doing
I would just ask that question because I've had other kinds of surgery in more recent years, and the anesthesia has thrown me into urinary retention.
Yeah.
And I know that feeling well that you were describing when you want to void and you can't do it, and it's building up in there. It is damn uncomfortable.
It is tough.
Right.
And I was telling my wife, and she said, oh, yeah, it happened to me once on a bus in Europe, and the bus driver wouldn't stop. I said, slow down, honey. If you had to go, you could go. So
Right.
Exactly.
Exactly.
She said, oh, yeah, I didn't think of that.
This is different.
right. Well, Jimmy, we'll be hearing how this progresses, hopefully in the right direction soon.
Yeah, because anybody that, you know, that has not, you know, this is not a common thing. I know it's not a real common surgery. A lot of guys, you know, don't even get that far. They get slings, they do their Kegels, they deal with it. And some people probably just go ahead and they remain incontinent because they don't want to have any more surgeries. They don't want any more things put in them. I understand that, but I hope to be able to report that it works well.
Great. Okay, well, we'll be hearing from you soon. I just wanted to notice that Wang Gao has joined us. Hi, Wang Gao, how are you doing? You're muted. Well, we'll get back to you as soon as we can, or when you check in. And we have a caller 02. Is that Mike? Mike, are you on the phone?
Yes. Yes.
Okay. Well, we can certainly hear you better right now. So I think we can proceed. So, okay. Well, great. The phone works. So tell us, how old are you, Mike?
Herb, my cell phone here looks like it's pouring itself out, and I'm going to try to give you all the vital statistics real quick. I'm 70.
Okay.
I live up in the Milwaukee, Wisconsin area. I had no clue of prostate problem prior to about 4 weeks ago when I had an MRI done for acute pain in the left leg and hip, and they spotted lesions all over the bone structure there, which kicked off all the testing. They claim the PSA was up at 450, and after the biopsy, the Gleason score is 9, and the bone tests and scans show the cancer in the pelvis, the leg, the hip, the backbone, and even some of the ribs.
Okay, so that's quite extensive.
Yeah.
And so where are you being treated?
I've seen 3 different oncologists, all specializing in prostate. One of them at Aurora in the southeast Wisconsin area here. The next one is at Froedtert Medical College of Wisconsin. And the last one was at UW-Madison. One of the oncologists recommended Lupron and Extendi as a treatment, and the other 2 have recommended Lupron and chemo. And I'll admit the chemo scares the hell out of me. And one of my questions is the quality of life on Extendi just as bad as that on chemo?
Well, I mean, I'm not on Extendi, but I'm on an equivalent regimen. And I mean, I think it's apples and oranges. The advantages of chemo are that if it works, you get 6 sessions of chemo. And if it's working, it does the job. The second generation anti-androgens are a much longer prospect and come with their own set of side effects. So I think you will have people here like me who had chemo, and Peter had chemo, and we came through it. And other people like Ken Anderson are on chemo even as we speak. And Jake has had lots of chemo. And then there are others that we've heard also who went directly to a second generation anti-androgen. But, you know, I think, so are you different oncologists? So the different oncologists are recommending different things.
True statement. What is a second generation anti-androgen?
Okay, so the Lupron, which knocks down your testosterone, is considered a first generation anti-androgen.
Right.
The Extendi, which is an androgen receptor blocker, so it blocks the receptor from androgen from binding to the receptor, is considered a second generation anti-androgen. So it's much more powerful and localized. And in your state, you certainly need something. I mean, the clinical trials would argue that chemotherapy versus Extendi or Zytiga, which is what I'm on, are somewhat equivalent overall in the scheme of things for newly diagnosed patients. So let me go through a few more other things. So did they do anything
Herb,
like a yes?
I'm just wondering if I might make just a quick comment, because it's kind of, I haven't given you my history, but I do have some info from the Mayo Clinic and my own situation that may apply to is it Mike that's talking?
Yes.
If I could just say this, I was diagnosed with advanced prostate cancer about 2 years ago, and had a PSA of 27, and so I needed to determine a treatment program, and I did a consultation down at Mayo Clinic about chemo versus the AR treatments, and my medical oncologist said that he would recommend chemo because the studies that he's been looking at suggest a longer survival rate if you do chemo first, and you can then do the AR treatments. But if you do AR first, you probably may not have as good a success. So I did the chemo, and it's worked well for me. So that was a Mayo between the AR and the chemo. If you could tolerate it, that's what they told me. So I just wanted to bring that to the conversation.
Let me just comment on that, which maybe I'm anticipating her, but the wisdom now in terms of treatment is that if you have low volume metastasis, which is why I asked the question to Stan earlier on, you go with an LHRH drug like Lupron or similar, and a second-line anti-androgen that could be enzalutamide or abiraterone. I will say that the studies seem to say abiraterone first, enzalutamide second, but it can depend on your own comorbidities, if you've got issues, if you're not going to receive the prednisone that well, but definitely Lupron and a second-line anti-androgen. If you've got high volume Metz, which it sounds like Mike Hanley does, then the wisdom is Lupron plus chemo up front. And my own experience, which goes back a long time now, is that the men who have done early chemo seem to do a lot better if they have significant metastasis, and even sometimes when they don't. I am curious, Mike Hanley, what type of doctors, you said you saw 3 different types of doctors. What were they all medical oncologists, or was one a urologist? Was one a radiation oncologist? Tell us about these 3 doctors.
Okay, the 3 were all medical oncologists, and the 2 that recommended the chemo are involved in urinary cancer groups.
Okay.
On prostate and cancer.
We're losing you again, Mike.
Yeah, we're losing you, Mike.
Okay.
Mike, we're dropping out.
Who was the medical oncologist at Madison?
I don't have that in front of me, sorry.
Okay, well, I think the bottom line here, because I don't know why, but even on the phone, you're not coming through that clear. Madison is an NCCN hospital, and the overall quality of care at Carbone is good. We've known several men who are being treated there. In fact, one of our younger men is in a trial at Carbone right now for lutetium-177. And if it were me, I would be running to Carbone for my treatment, because overall, I have much more confidence in what the people at Carbone are saying than probably any other hospital in your area, unless you head south and go to Northwestern, for example, or University of Chicago, where we can also recommend some good doctors. But but Carbone is good, and so
okay. So nobody has experience with Froedtert Medical College of Wisconsin. They also have a prostate urologic cancer program there.
No, we don't. That doesn't mean to say they're not good, but we don't. And we would like, I would be asking you, who are their medical oncologists who have, are you sure they're not urologists? They call themselves urologic. No. They're not urologic oncologists?
No, it is a medical oncologist. Dr. Geaver is the one that I saw there.
Okay. Not a name I'm familiar with.
Could you give us that name, Mike? Could you pronounce his name again?
Geaver, G-I-E-V-E-R.
Geaver. It's not a name. I mean, we know through collective experience here, we have years and years of collective experience. Not a name we recognize.
Okay, all right.
Which means that he may, doesn't mean he's not a good doc. He may not have done much research, just haven't heard from him. But as a whole, as a rule, you're going to get the best treatment for advanced prostate cancer at a hospital that's either an NCI hospital or an NCCN hospital. And Carbone fits into that, as does Northwestern.
Okay.
Right. And what I just looked up, Dr. Giever does not have a specialty in prostate cancer.
According to the hospital, he does, but okay.
Well, according to what I can see on the, his own web pages, he just lists medical oncology and hematology. He does not list a specialty in prostate cancer. So I would strongly agree with Rick. You need to be at university.
But there is another listing that says he's genitourinary.
There is?
Yeah, I'll paste it in the chat.
Look, guys, I don't think, I mean, let's accept that he is a GU med-onc, but even if he is a GU med-onc, I still would encourage you to consider basing your care at an NCCN or an NCI hospital. And because I think in the long run, with complicated, extensive disease, you're going to get better treatment. And if you need to stay on top of clinical trials, it's going to be much, much easier to do that at an NCCN or an NCI hospital than at Frida Medical Clinic.
Okay. I've got that noted. I appreciate it. Thank you.
The other thing is, who was it? Was it Giva who recommended the abiraterone, the enzalutamide, and the Lupron?
No. I'm sorry. Which drugs? Do you mean the Lupron and the enzalutamide? No, that was at Aurora Health Center.
Okay.
And that doctor is not specialized in.
Okay. Well,
in prostate.
I don't know.
So you're saying that both the docs at University of Wisconsin and MCW are recommending chemotherapy.
Yes.
So I think given what we know about those institutions versus the local one, I think you're well advised to start out that way.
Okay.
I mean, you can come back here, you can talk to the guys who have done the chemo. We can support you. We will support you. We will help you. I am eager to know who the doc is at Madison, because we know a couple of those docs, and a couple of them are really pretty good. So I'm just looking here. Just bear with me 1 second. Let me just see who Dennis McGuire's doc is. I should remember, but I forget. He is seeing. Oh, that's Floberg. Floberg was his radiation. Lang, of course. Was it Dr. Lang?
No, it's a much longer name, foreign sounding.
Okay.
But I think, we certainly are. Think the other thing that has been suggested, and Peter, maybe you want to bring this up right away, is that genetic testing may be in order for you.
Trying to find out if they have that or not.
They'll certainly have it at the University of Wisconsin, at Carbone. There's no question they will do it.
Okay.
And we think it would be very wise to do it early.
Okay.
Mike, do you have any other cancer in your family?
Not that I know of.
Okay. Well, look, keep coming back. We'll figure out the technology, and like I say, if it was me, I would be running towards Madison, not walking. I'd be running and getting yourself into treatment at Madison.
Definitely.
Okay.
So keep
and
us informed, Mike.
I will do that.
But I think you want to get your
And-
appointment set up at Madison pretty quickly. You don't want to
Right.
sit on this.
No, I do understand that. Yeah.
Okay. Well, if you have any other questions, please, you can email us and we can deal with this offline.
Okay. Good enough.
Okay. So moving along, and I'm going to call on Ken Anderson, who is texted me that he might be asleep. So Ken, are you with us? I think Ken is also going through some chemotherapy, and so I think he's getting pretty tired. So we'll hopefully Ken will wake up and rejoin us. So Alfred, would you like to say something tonight? Alfred, you are muted.
Forgot about the mute thing. You hear me now?
We can.
Yes, we can.
Okay, I had two questions. I'm going to leave it to the quickest one tonight since we're already really late.
We're okay, don't worry.
Dr. E left MD Anderson, and they have now reassigned me to Dr. Logothetis. I was wondering if anybody there had had experience with him. I actually have a long history with him. I was seeing him for 9 years, and he was a good doc, but I didn't like his bedside manner. I was just wondering if anyone else had any experience with him.
Well, it's a tough question. He is a really good doc.
Sorry, let me interrupt. The other thing you mentioned that he was retiring also, and apparently he's still there.
Well, he's retiring from the chair of the department. He wasn't retiring from practice. He was retiring from. He was the head of the department.
Oh, okay, well that makes me feel a little better that he's not leaving in 2 or 3 weeks also.
Right, and we know a couple of people who have applied for that chair, and I think his sort of the chair is in his shadow, shall we say? I think that's probably the issue with Dr. Logothetis. Very, very fine doctor, knowledgeable, but he's a bit old and crusty, and I think that's what you got to take into account. And maybe not the easiest person to work with, and that is probably true both with his patients and his colleagues.
So anyway, I appreciate that. I mean, he was crusty 20 years ago too when I first saw him. So anyway, I'm kind of used to that. I guess my main thing was the thing about him retiring. So he's not actually leaving MD Anderson. So okay, that makes me feel a little better. Thank you.
Okay.
What's your other question, Al?
Well, the other question. Okay, well, we can put this on the table. This hasn't come up tonight, but almost every week, every time I join, someone's complaining about the side effects of Lupron. But no one ever talks about using estrogen instead for androgen deprivation.
Right.
And I'm just wondering why. I mean, I'm doing it and I feel like a leper because no one else is doing it.
Well, we're going to ask David Muslin, who recently had a call with Richard Wassersug and a couple of other guys. Oh, Jimmy was on that call too, to tell us what he learned and what he thinks about the possibility of using estradiol instead of LHRH. David.
Well, Albert, you're probably one of the smarter guys than everybody else, because what Richard says is the reason we're all on Lupron is because it makes money. Where the estrogen, he's been on it for 20 years, and he's in great shape, and he's a 25-year survivor, and that we all really should take a look at it. You know, come to think of it, Rick, it'd be great if he could come speak in one of our meetings one night. But he's a big proponent of it, and we should all be looking into it. And we can read about it. I'll actually send something around that he sent. But that's his position, and seems to be a brilliant man. And he says everybody's on Lupron, we're all missing a boat. I shouldn't say missing a boat, but he says, you know, just look at himself. He's been on it for 20 years, and I don't want to repeat myself, but that's a great question, Albert. And so tell us about yourself. Talk about it.
Well,
tell us what you've been doing.
I'm a 25-year survivor also. I was on Lupron with Dr. Lulithidis for 9 years. I complained to him about it every time I went, and he said, just live with it. Eventually, I left there. I went to Dr. Snuffy Myers in Virginia and told him about it. And he says, well, let's try estrogen plus Avodart. Instead, I got equal amount of, my testosterone was equally low. And I felt a whole lot better. And it's been 16 years now. So I'm wondering why no one else does it.
I think maybe that's what we may need. I think this is right for a webinar. We need to have.
It is.
I think we need to have a webinar on this topic.
Jimmy, did I miss anything on Richard? I kind of went right to the bottom line.
He talked about, using it for hot flashes and using it for suppression. So obviously be used differently for those two things. And he said, I think something about dosage can be a little bit tricky, but did you just kind of find it? Don't let it get too low or too high. Does that sound familiar, Al?
Yes, well, Dr. Myers had apparently been using it some, and he put me on, I use the patches, and I wear 3 patches at a time, and I change one each day. And also I take Avodart twice a week. And that was my formula for almost 10 years. It kept my PSA below 0.1. And of course, everything eventually cancer finds its way around. Whatever you're doing, it finds its way around it. So eventually, I had to start doing other things too. In addition to, I am still on it today. Now, I was not told about radiating the breasts beforehand, and my breasts got totally out of control. I had a double mastectomy about 4 years ago, and that solved that problem.
So, Albert, are you on any other drug besides estrogen?
Estrogen, Avodart, and right now Lynparza. I was on Xtandi for 4 or 5 years before it failed, and now Lynparza is failing also. So
let me ask you, Al, last time we talked, we suggested you look into getting an updated genomic sequencing. Have you pursued that at all?
Well, I haven't actually done that, but Dr. A at Johns Hopkins wants to actually have a biopsy of one of those lymph nodes and get some real tissue to examine and foundation. So yes, I am pursuing it.
Okay. Well, if it turns out that the lymph nodes are not biopsyable, which often happens with lymph nodes, then fall back onto the liquid biopsy because it's probably better than a bone biopsy. Because the bone the problem with the bone biopsy is that the chemicals that they use to macerate the bone, break it down, may, in the view of FMI, Foundation Medicine, make it less reliable than a liquid biopsy today. They think they can do better analysis from the circulating tumor cells than they can from the macerated cells they get from a bone biopsy.
The liquid biopsy is just a blood test?
Liquid biopsy is just a blood test. The ideal is exactly what Dr. A says. If they can get soft tissue, that's what they like to have. That's the best. But it's not always possible to get soft tissue.
Anyway, that's a work in progress at the moment.
Okay, and I just want to just put in a quick, before we go to the next person, or if anybody has anything else for Al. We try not to mix presentation with support. And the reason for that is, as you can see, we don't have enough time for the support. So to take a chunk out of a meeting to have a speaker like Richard Wassersug means we get a lot of unhappy people, because some people don't want the support, but they want the information. Others want the support and not the information. What we can consider doing, and we can definitely do it with Richard, he'd be happy to do it, is either to schedule a webinar or to schedule an extra session where we just talk about estradiol and we invite him in, if you guys would be willing to come to another meeting like that. And we'd have to figure out how to fit it in. It could get a little complicated. We can probably do it. But I don't see us, I see us inviting Richard to meetings. He's been here before, but we can't, if we devote half an hour to a discussion on estradiol, we're dead on arrival.
But I do think it's worth a discussion. I mean, especially thinking it through, Rick, estradiol plus a second generation anti-androgen seems like a perfectly reasonable approach.
Yeah, I agree.
And I think I'd like to hear more about it.
Just one last question for Al. Al, what is the most palpable side effect difference that you feel with that versus Lupron?
I don't have the brain fog that I had with the Lupron. I don't have the fatigue and loss of energy that I had with Lupron. Actually, it's a little bit vague now because I switched more than 15 years ago now. But as I recall it was to me it was almost like night and day, the difference.
Interesting.
At the time I started the estradiol, I had been off Lupron for a few months, so I was already feeling better, and I didn't feel that the Lupron cloud come back over me. And I've been very active. I mean, I was only 46 when I was diagnosed, so going on Lupron was really a chore back then. It really changed a young man with young kids' life.
So Peter has given us a good suggestion. We have a fifth Monday that we may be able to use. It is a Seder night, Peter. I think it's the first or the second night of Seder. So some of us.
First night, I think first night is Friday night and second night is Saturday night.
I don't think so, but I'm not sure. I think Monday's the second night, but I could be wrong. But let me ask, and then it's a question of whether Richard is available. But we could try and do something to get Richard in to talk about, and we would just limit the meeting. It wouldn't be a meeting where we welcome new people and we go around everybody. We'd just be talking about estrogen therapy versus LHRH. And I mean, just give me a quick show of hands. If we did that, would it be
March
supported?
28 is the first Seder.
It's Saturday
No.
and Sunday.
Saturday and Sunday, 27th
Saturday
and
night and
28th.
Sunday night.
Okay, so the 29th, and so how many people would be interested in attending something on estradiol? Okay, so about
The
half.
other thing is, I think we need to get Dr. Mark in on this.
Okay,
I think he knows a lot about these kinds of hormones.
yes, he does. Yeah, we could, what we could do is get him to even maybe moderate.
Mm-hmm.
Okay. Okay, I'll work with one of you guys. I don't know if I got the bandwidth to set this up right now with everything going on, but I'll work with one of our moderators and we'll see what we can do.
Okay, before we run out of time. So I'm gonna, Al, I'm gonna move on if that's okay.
That's fine. I took more than I thought I was going to get, so that's great. Thank you.
Okay, so Alan, what's up?
Okay, I'm going to try to be very brief and focused because I don't want to take much time. Okay, so I'm one of those who had prostatectomy a number of years ago, radiation, PSA, as many of you might remember, has been creeping up. Had a bunch of scans that haven't found anything, and I see my medical oncologist tomorrow at Sloan Kettering. My PSA doubling time is going up a little bit. It's about 18, 19 months right now, depending on which data points you use. It could be as high as 22 months, for example. And my latest PSA is 3.3, and that's up from 3 months prior at 3.07, and 3 months prior to that, it was 2.96. So happily, it hasn't gone up a whole lot over the past 6 months. And so a few focused questions. I mean, one, we did say last time that I should consider an MRI because maybe my cancer is not amenable to Axamin or PSMA, and I will discuss that again with my oncologist. I know he's supportive of it, and I've held off, frankly, doing it because my PSA hasn't gone up that much, and I've had some other things to deal with, but I will not forget that. First question is there any sort of test that I could take? Maybe it's the liquid biopsy or something else that would give me a measure of aggressiveness of any of those cancer cells circulating in my body. Remember, no one's found a tumor. My prostate tissue is probably too old to use. It's coming up on 8 years. So that's my first question. Is there anything out there? I don't believe there is, but I thought I'd throw it out there. Okay, so keep that in the back of the mind. I don't want to take time. The second question is a little hard, which is this. What questions might I want to ask my MO tomorrow? You know, we'll talk about the MRI. We'll talk about the idea of doing another maybe PSMA scan when I hit maybe PSA 4 or in that range. But other than those things, is there anything else I should be asking him that you can think about that I'm missing? In the past, I like to stay ahead of the game, so to speak. And so sometimes I ask him about, well, treatment. If I need treatment, you know, what do you recommend? And, you know, he didn't know much about the new Relugolix at the time. Maybe he knows more. You know, I might ask him, do I take a drug with that? Would that be better for me? Any other thoughts that pop in people's minds?
So the first thought I have, Alan, is since you at 2.33, your PSMA scan showed nothing. You know, the question.
Okay. My last PSMA was done at 2.
Well, I have it that it was in March of 20, you were at 2.33.
Yes, that's correct. Okay. Yep.
Right. So it didn't show anything. And the real question is, for me, is maybe you don't make PSMA. Some men don't make PSMA. So maybe in your situation where your PSA is high enough, you should consider an Axumin scan.
Right. So I had that one at the PSA of about, I think it was 2 in November of the year before, 19, I think it was.
And it didn't show anything.
Yep, nothing.
Right, I see that. So maybe I have that noted too. So maybe it's worth doing an Axumin scan this time to see if anything shows up.
It could be.
Right? Because something's happening. We know something's going on. Second question. About CTCs. You know, at 3.7, you might, you know, I think that's sort of around the margin, and you may be generating CTCs. Now the question is where they're going to send it to, or if they're going to do it in-house, because MSKCC does a lot of their own stuff in-house. But and I don't know much about their in-house criteria, but it might be worth saying, look, could we do a liquid biopsy here? You could certainly get a liquid biopsy from FMI, but can we do a liquid biopsy here and see if we get any results? See if we're showing any mutations. I mean, we're only, if we see certain mutations, we do know that the prostate cancer could be aggressive, like a P10 or a TP53 or something like that. We don't necessarily have treatment, but it is an indicator as to how aggressive the disease is. Herb, what would you say on the CTC?
Well, I was going to say, it's not only mutations, it's essentially the number of CTCs per milliliter. So basically, if you don't have a tumor that's making PSMA, and you have circulating tumor cells that are just not PSMA avid, they will show up on a liquid biopsy. They can, I mean, the other criterion is how many tumor cells do you have in a sample? They'll take the sample, spin them down on a slide and count. And then they'll also be able to do histology on those cells. So a pathologist could actually look at what those cells are making.
So I was under the impression, maybe mistaken, that that test was only really suited for when, let's say, you still had a prostate gland, or whether you had a significant size tumor, and that it might not even be realistic for a situation where you haven't really seen much at all.
Yeah, but we don't know why we haven't seen much. This is what we're trying to find out.
Yeah, I understand. Okay.
I mean, Alan, you said you just said before that you were into all this taking the no chances. So to me, having a liquid biopsy at this stage would be sort of insurance.
Okay, that's a fair point.
If it shows no circulating tumor cells, then they can certainly say you don't have a significant tumor burden.
Right. So my choices for getting that test. So you mentioned, is it Foundation Medicine?
Yeah, and I mean, the Foundation Medicine test liquid biopsy would be covered for somebody like you.
Okay.
Covered by Medicare, that is.
Right. Is there an alternative or an additional test you'd recommend?
Guardant is another provider.
Oh, what was that?
Guardant. Guardant.
Okay, Guardant. Okay.
Guardant is another provider, and there's another one as well whose name fails me right now. Anybody remember?
I read last week that doctors use a Prolaris test to determine whether or not a cancer is aggressive. Now,
well, yes, that it is, but that's used after surgery, Joe.
Okay, very good.
That is a test that is used to determine, but it's usually used right after surgery. I don't know what it would tell right now, and I think they take prostate tissue from the surgery and that was a long time ago that was how many years ago was that for you?
That's 8 years this month.
8 years ago. So I'm not sure. But there is one other, and I'm just not thinking of the name right now, but does anybody else know the name of the other?
Caris.
Caris. Thank you, Peter. Caris.
How do you spell that? Is that a K? K-A-R?
Caris.
Okay, good. All right, that's very good for me. I think that's all I needed to know right now. Unless there's something else I should ask the doctor, but I think I got
Alan,
good topics.
Alan, this is Len. You asked what would if it were me, I would ask my oncologist, look, if my cancer is not producing PSMA and if it's not producing much PSA, how would we be able to detect whatever might be there?
Good.
Right.
Like what techniques would you use? Maybe he'll tell you the liquid biopsy, or maybe he'll say MRI, CT, or FDG, but FDG PET. You know,
Right.
Just find out what would be used.
Good. Thank you. That's another good point. Yeah, I was seeing him tomorrow, and then probably in a month or so, I will see Dr. O. I have to set that up, and I'll get another opinion on those questions. Very good. Thank you.
Is it Yu Chen? Are you still seeing Yu Chen at
Yes.
MSKCC?
Yes.
Okay.
Okay, Ellen, thank you. We will keep us informed.
Yes. Thanks, everybody.
Okay, Gary Peters, what's up? You're got to unmute.
Hi.
Hi.
First, a couple of quick questions just from what people said tonight. Stan, you were saying that you're taking a low dose of prednisone. What is your dose?
5 milligrams.
Once a day or twice a day, Stan?
Once a day.
Okay. Thank you.
And Jimmy, I was going to ask you, who was your original surgeon at Hopkins?
Muhammad Alaf.
Okay.
A-L-L-A-F.
For what it's worth, I didn't have exactly the experience you did, but a similar experience where they could not get anybody in that entire hospital to address something that led to a bigger complication. I was personally very disappointed in the patient care that I got at Hopkins in Baltimore.
So Gary, are there other issues that you think we can help you with?
Yes. I had I had a prostatectomy in September. I'm on Lupron and abiraterone. I'm scheduled for 8 weeks of radiation therapy starting in April. I believe that I'm going to be able, I believe my insurance company is going to approve proton therapy. My question is, do I want that? Is it actually any better than IMRT?
So the answer, there have been no head-to-head trials, although I think there is one under study. We don't have anybody here who's the real expert on the SWOG and ECOG trials, but I think there is one right now. And we've got guys who have done IMRT on this call, and we've also got guys that have done PBRT, and they'll say their piece. The one thing that I always rely on is a study that was done a few years ago. If I can find it, I'll put it in the chat window, that says that the side effects from IMRT are less intense in the GI tract and more intense in the urinary and rectal area. And the side effects from the PBRT are more intense in the GI area and less intense in the rectal and urinary area. And at the end of the day, it's probably 6 of one and half a dozen of the other.
Rick, if it's saying more intense in the GI area and less in the rectal urinary area,
well,
what sort of effects in the GI area?
I can't tell you. I'd have to go back and look.
I mean, the other thing, Rick, you sent me to Mac Roach, and I've talked to a gazillion radiation oncologists before I went for my treatment. And the one thing I really learned from talking to them is each person is different, that your anatomy is different, and that the effect and the direction they can give radiation for each of us is going to be different. So the bottom line is you need to pick a method where the radiation oncologist has calculated that it will do the most good where they want good and do the least damage where you don't want damage. And whether it's IMRT or SBRT or other or proton, I think that's really up to your anatomy, Gary. And it's really not, I don't think you can make generalizations from this. So depending on your anatomy, if they can get to where they want to get to with a proton beam and not hit anything else, you're in luck, right? But if they think that there are too many other things going on, they may need to hit you from different angles, which might require IMRT. So I don't know that we can, I think there are, yes, each one is going to have side effects. There's potential side effects. And, just like people who do robotic surgery will try to tell you, well, there's not that many side effects. Well, it depends on you. If you happen to have a nerve that was in the wrong place, it can be unfortunate. And a surgeon won't know that in advance. So I think really it's a more specific decision for you.
I agree with Herb. My radiation oncologist told me what the best treatment for me would be. Ended up to be SBRT, but he made the decision and I accepted his expertise because he did all methods of radiation at Sibley and Fairfax and other places.
Thank you.
Yeah,
Who was
I actually
that?
had
John.
This is
John Ivory.
John, I had proton therapy, and I chose it because the doctor talked to me about the physics of it, and it seemed like it would have potentially less harm to my bladder and my intestine. I'm not sure. This was now 10 years ago, so I'm not sure how the radiation has changed, but I made the choice because of that.
Thank you.
So, guys, I put the link. Hold on a minute, Jerry. And hold on a minute, Jerry. I put the link to that study in the chat window. The IMRT versus PBRT. So you can all take a look and see what you think. Don't shoot the messenger.
Right, exactly. So look,
Okay.
Gary, okay,
Can I
you'll
talk?
let us know. Sure.
Go ahead, Jerry.
November of 2019, at Mayo in Phoenix, or in Scottsdale, I had proton therapy, 20 of them over 4 weeks. And I researched it very much like John, and decided on proton. And to tell you, I didn't have, and I still don't have any side effects from using proton. So,
Jerry, who was your doctor?
Who was my doctor?
Yeah, because it might have been the same doctor, because mine went out there after she treated me.
Oh, this was the head of the department, Richard.
Different person.
Richard Shields.
Yeah, different person. Thanks.
All right.
Thank you.
Okay, so Gary, I think, depending on your anatomy and where they want to hit, I think proton could work or not, depending on the other choices. But I would, again, if you trust your radiation oncologist, you don't have much choice.
All right.
But the question I would ask is, what is my anatomy? What are you going to do to make sure you don't hit these other organs?
Right. And who was the person who had the doctor at Sibley?
I think Joel, right? You were done at Sibley.
I was done actually in Loudoun County, Virginia, Loudoun County Hospital, but the doctor practiced at Loudoun, Fairfax, and Nova Shore Center and Sibley. He no longer goes to Sibley because they now have a proton machine at in Nova Shore Center. So the only reason he went to Sibley is because the machine was there.
What was his name?
Dr. Veblen, E-B-L-A-N, Veblen.
Okay, thank you.
Okay, it's getting late, so I think I want to move on. Ken, are you awake and with us? Because Ken said he was awake.
Yep, I'm here. Yep, I'm here.
Great.
I'd like to say you're doing a good job, even though I missed half of it. Yeah, completed round 14 on Friday, so I'm on my third day, which is usually not a great day for me, but I wanted to kind of give an update as far as PSA. My PSA did go up 4 points, so right now it's at 22.5. I'm not exactly sure what's next. I put in an email to Korn at MD Anderson, so I'm just waiting to see. The funny thing, my ALK phos went down and my PSA went up, which is unusual because normally they follow pretty close as far as parallel. So maybe there's some activity outside the bone. I don't know. I need a scan for sure. That's about it.
Well, keep us informed, but I think obviously you know what you need. If there's anything we can help, right?
What's that?
Rick, you have a comment?
Yeah, my comment is, Ken, that these are within the overall picture just relatively small amounts.
No, I know that. Good. It didn't make me crazy.
And yeah, I mean, it will make you crazy, but we look, and yes, it's been slowly going up, 17.1, 19.5, 23.5, but your ALK phos is going down and down. And so you just have to take it into account. I mean, we're not seeing the big sort of jumps, say, that Jake was seeing.
Right. No, I told Paul in my email I was prepared to do round 15 and see where it goes. If I have 3 rises, I'll probably ask him to switch and do something else.
Well, you've had 3 rises, 17.1, 19.5, and 23.5.
No, you're missing one, Rick. I'll tell you as soon as it loads. My PSA was 16.1 in January. Then it went up to 18.4 in February, and now it's 22.5. But it had been going, it went down, it went up in December, and then it went down in January, then it went back up in February, and now it's up a little bit more in March.
Wait a minute, put me picture. I've still seen 16.1, 18.5, 18.4, and 22.5. That looks like 3 consecutive rises to me.
Okay, I'll tell you the entire thing. December was 20.8. And in December on the 31st, it was 17.1. In January on the 22nd, it was 16.1. In February on the 12th, it was 18.4. In March, it was 22.5.
Right. Isn't that 3 consecutive rises? Or
it's
three.
No, because it went down. It went down 1 point in December. But again, they're minute. It's minute.
You're right. It's 3. It's only 2 rises from 16 to 18
to
20.
No, I agree, Rick. They're not huge rises, and you said it's okay to go. I'm not going mental about it. I'm fine with it. Not fine, of course, but
right. But I just think that maybe, here's what it looks like. I've known guys that have done 40 of these docetaxel treatments, and what it looks to me is that it is doing a great job keeping your disease in check, but not without taking a toll on you. So you could probably keep on like this for a long time.
God, I
but
hope
the question is, you've got to decide, do I want to keep putting myself through this time and time again, or am I strong enough to do it? And if I don't want to keep doing it, what are the alternatives? Because I think this is an important discussion, not just for you, for everybody. How long do you stick with a treatment that it's not reducing the disease, but it's certainly keeping the disease in significant check?
I think for many of us, that's what it is. Not necessarily chemo, but whatever.
What's the definition of significant? PSA, Rick.
Well, I think it has to do, I would say it has to do with doubling time. And what's that doubling time, Peter, that you always refer to? 2 months, 3 months, is that it, Peter?
3 months is the thing. When chemo starts to fail, a lot of guys go up like 1,000 points a month.
Right.
Yeah.
So, yeah. So Ken, I think we're getting late, and I'm wondering, there are a couple of more guys that
move along. It's fine.
But keep us, at least it's not going up by much, and it means it's still working. So, all right, I want to actually note it. Wang Gao joined us, and let me know if you would like to talk at the end. If we have time. Otherwise, I think Frank, would you like to talk to us?
Sure. Had my 4th chemo on Thursday. Before the chemo, got some very solid news on the blood draw. My PSA dropped another 0.1 from 0.37 to 0.27. White blood cell count was 1145, and hemoglobin was 10.8. Okay. So the docs felt that with the treatment, those are holding steady, and they were satisfied. So that was very positive to see that. I start on Orgovix Thursday in place of my 6th Firmagon injection. So that's going to be interesting to see what happens with that. The VA sent me my first batch of pills for that.
and I'm anxious to get that started. As with Ken, I'm in my 4th day after chemo, and it hit pretty hard today, mainly in the intestines, the stomach, and I still am struggling with the taste issues, saltiness with water, and food just tasting bad. And I don't believe there's any way around it.
When I was on chemo, all I could drink was tomato juice.
Yeah, I can't handle tomato juice. I tried it. I tried both different kinds. That didn't do it. I have maybe 6 things that I can tolerate, and not it flip my stomach. And I just have to stick with those. I've made up my mind. I can get through it. But overall, I'm positive, and I'm ready to move on with number 5 on April the 1st. It won't be April Fool's Day for me.
Good for you. Good for you.
Good for you. Those numbers sound great.
Yeah, I was. That was pleasing. Very, very happy. The amazing thing is that at the James Cancer Hospital, I'm sitting in the waiting room waiting for the nurse practitioner before my doc, and I get all the lab results in a matter of 30 minutes.
Mm-hmm.
So I get to see them at almost the same time that they're talking to me about them.
Right.
That's great.
Frank, if you go to the ACS website, cancer.org, I'll see if I've got it bookmarked, but I can't find it right now. There's some really good tips on taste and smell and taste whilst you're on chemo. I mean, one of the things that always sticks in my mind is avoid using metal cutlery. Use plastic cutlery whilst you're on chemo. Another is there's a mouthwash out there that's supposed to be pretty effective. Any of you guys who have been on chemo, any tips for Frank on this, metallic taste issue?
One that the doc recommended, they called it magic mouthwash.
Right.
And it didn't do any good. It just seems that the first week and a half after chemo is the worst time. And then it starts to slope off a little bit towards the end, but then right back with the other treatment comes right back strong. But yes, I've been, somebody had recommended on one of the calls back before I started, after I started chemo, to use plastic, and that's what I've been using, and that's helped some.
How about pasta?
Say that again?
What about pasta?
No. The eggs, pasta, just a complete turnoff.
Wow.
I try to explain to my wife, Gail, to me, the best term I can use, it flips my stomach. I take 1 bite, 2 bites, and I can feel it almost immediately, and the brain turns off and says, stop it. And I just can't, I just have to go away from it.
Frank, what did you say your white blood count was?
It was 11.45.
That sounds really odd to me. That sounds very high. Really.
Well, as all I can say is that the oncologist was satisfied with the results, with the past results, and I am getting Neulasta along with my chemo. They have that little device now that they attach to your arm, and it dispenses 27 hours after treatment.
Right. I got that too, but I was down in the 3 and 4 range. 11 is
No, Peter, you're pretty low. Mine runs right around. Mine runs right around 11.9 to 12.2 over the last 14 cycles.
Well, that's great for you guys, because that's way high.
You were just super low.
No, but the range goes up to 10.8, so you're in a pretty high range. That's great.
Yeah, I know. As I said, I can only count on them, but they looked at the results and they were just pleased as pie. And I said, okay, let's go.
Good. Great, Frank. So you will keep us in the loop.
Sure will. Thanks a lot, guys.
Okay. Jeff, Marchi, you're still here, and we are too.
Can I just say to Frank, I just put a link in the chat window for you.
Hi, Jeff. How are you?
All right. I keep forgetting to say this when I talk about hot flashes. And after taking ADT, I was miserable. I had hot flashes almost every 2 hours. And I really had an issue with fatigue because I had, just before a hot flash, I hit with major fatigue. I found the only way to stop the flash was drink 12 ounces of very icy water and fan myself vigorously. That'd make the flash bearable, but not the fatigue. Then my doctor, after a year, told me about Depo-Provera. I got my first shot, and 10 days later, the fatigue was gone. I have never had the fatigue since for over 2 years. Mild flashes are about the worst I get until I have to get a shot every 3 months. About 10 days before the 3 months, I start getting flashes again. I get the shot, and they last about 8, 9 days more flashes, and then they stop again. Even after taking Abby, about 2.5 months now, I only get hot flashes at night. I take a couple of CBD at night to reduce those. I was getting 4 at one point. They aren't very hot. They're just a little warm. During the day, I don't get them. So I just thought I'd mention Depo-Provera has, for me, stopped both the hot flashes and the fatigue. I never have a fatigue problem anymore. May not work for everybody, but I figured I ought to mention that.
Yes, for sure.
And Depo-Provera is an estrogen product.
It's it's just the opposite. It's an anti-estrogen. From what I've read, it actually, is an anti-estrogen.
I don't think so. I think and the reason I say that is because the reason you get hot flushes is because you don't have enough estrogen, because the LHRH drug is preventing you making estrogen.
The Depo-Provera has progestin, not
right. It's medroxyprogesterone.
Okay, so it's a So sorry, not estrogen. It's a progesterone, but it is. Isn't progesterone an estrogen-like substance?
I read it. I just looked it up, and it said that it's the opposite of estrogen. But I'm not.
It's something where I think we'd hear from Dr. Mark, because he uses it. He used it a lot, but it's basically a contraceptive. It's a long-lasting contraceptive, suppressing estrogen secretion. So
right.
I don't know why.
Suppressing estrogen.
So why it works, I'm not sure. I'd have to read more.
Yeah, well, my urologist, the chemo urologist knew about it and told me after a year. So I just figured people should know, because, like I say, it stops the fatigue and the hot flashes. I'm going to let you go because it's late. That's all unless somebody wants to comment.
Okay. I guess there are a couple of people. Wang Gao, you did come in, and we know you're here. It's late, but if you have something you want to share with us.
Yes, I'm actually still in Panama, but I'm heading back to Portland, Oregon in OHH in early April. Since I've been down here, I've seen as a second or third opinion a radiation oncologist and also a medical oncologist. And they pretty much agree with what both Dr. Vogelsong and the OHSU team has said about the various things of moving forward. When I was down here, I had my second Eligard shot, a Tolmar produced Eligard, and my recent PSA tests, which were 3 months from November 18th, which was right before I got the first shot on December 1st. At that point, November 18th, my PSA has dropped down to 0.146 after the first 3 months after the first, 2.5 months after the first shot. So now I've had the second shot. I haven't experienced any negative hot flashes, side effects. My stamina and ability to carry on.
So is there, well, yeah, I'm having real trouble hearing, and it could be me.
No. You're not coming through great, Gashan. Not sure
Can you hear
why.
me?
A little better.
So it's late. Is it, would you like, I mean, I think the other choice is really, can we continue next Tuesday?
Okay.
Is that okay with you?
Yeah, I'll be here next Tuesday.
All right. And Bob, I see you're here, but again, can we, if you have to, we hope you come back next Tuesday.
Thank you. I would like to do that.
It's late, and so we really pushed this to the limit. So I want to thank everybody for sticking on and listening, and we'll see you all next week.
Herb, you did a great job. Thank you. That was great.
Appreciate it. Bye.
We try. Okay, take care,
Yes,
guys.
Thanks, Herb. Great
Rick,
job.
stay on for a minute.
Thank you.
Okay.